And this will be a brief overview of endodontology. So let's first, my mentor always used to say, let's first throw out a question and build on it for the next 2 days. The first question I have to ask everybody is, why? Okay? What's the purpose of root canal therapy? Why are we doing endodontics? And the truth is, there's really a simple answer. To prevent and cure apical periodontitis. That's the reason we're doing a root canal. It has nothing to do with white line syndrome. It has nothing to do with how it looks on a radiograph. It has to do with the fact that we are trying to prevent and cure apical periodontitis. That's the reason we're doing endodontic therapy. So let's build on that. What is apical periodontitis? Well, without sending everyone back into dental school, it's really simple. I want everyone to realize it's an inflammatory process in the periradicular tissues caused by microorganisms in the infected root canal. The reason it's important for me to call this out right now is I want everyone in this room to remember a simple fact that you know. But we sometimes forget that one of the greatest studies done was actually by Seltzer and Bender right in Philadelphia. And that's when they used to yell at everyone and say, stop giving antibiotics just because the patient's in pain. You don't give antibiotics just because the patient's in pain. And the best example I always got from my mentor was this one. My forearm's healthy. I take a ruler and I start hitting it. After 2 minutes, ow, that hurts. I have inflammation. Guess what? There's not an antibiotic in the world that's going to take care of that inflammation. You can have inflammation without an infection, but I want you to know something. When you have an infection, there's a good chance you have inflammation. And that's what we have to realize. And the reason many of you are going, well, who cares about the forearm? Really? You're working on restorations. If that is out just a little bit from the normal occlusion for that patient, you're creating that same scenario. When that patient starts biting down, you're starting inflammation in the same place, but it's not as a direct result of the microorganisms in the infected root canal. It's for a different reason. So we have to make sure we understand that giving them an antibiotic is never going to take care of anything. And we also have to remember that Seltzer and Bender told us a long time ago, don't look at a radiograph and think you're diagnosing anything. Remember, you have to have 50% bone loss or a breaking of the cortical plate just to see something on a radiograph. You know, we look at two-dimensional radiographs every day. They're horrible, and we work in a three-dimensional world. Okay? So we have to make sure we know what we're reviewing. We also have to look at the real literature, and the real literature is right here. In 1965, Kakahashi got a hold of germ-free mice. He took 25 germ-free rats, and what he did was he exposed their pulps. Now that was compared to approximately 15 conventional rats that had bacteria. Exposing both pulps, it's probably not a surprise. Those that were conventional with bugs all developed inflammation and lesions. The crazy thing was, those that were germ-free never had inflammation and never formed a lesion. So guess what? That's how we as endodontists know it's all about bugs. It's 1965. We know it's bacteria-driven because of Kakahashi's study. His germ-free rat study is the reason we know it's all about bugs. So let's now address that. The pathogenesis of apical periodontitis. Here we go. Normal healthy pulp becomes inflamed. Okay, well, why does it become inflamed? Here's a few examples. One, caries. We all know bugs can cause inflammation. We all know that this can actually cause the pulp to become inflamed, and I'm going to build on that a little bit in a second. Next, we can have fractures. One example is what was described by Cutler and Berman. They called it fracture necrosis, where you get a fracture, bacteria can get in, and actually that causes necrosis of the pulp. Well, obviously there would be inflammation prior to the necrosis. So fractures can definitely do it. Also, we can do it as practitioners. Remember, Spears does a great thing, and he goes through a lot of stuff when Spears talks. Spears is phenomenal. And one of the things I want all of you to understand is, if we're using burrs that are old, we're taking longer to cut our prep, and we're applying more pressure over that time. And believe it or not, we're more likely to have a pulpitis. The only thing I can't tell you is whether or not it's a reversible or an irreversible pulpitis. That's a key thing for all of us to demonstrate and review. Next, we also have to think about when it's thermal, is it just the burr? No. I want to encourage anyone who's redoing their office, please put a water filtration system on your office. Have the water reviewed by a local company that actually does water purification. It's not that I'm telling you I want just sterile water, because I know we can all talk about biofilms. It's another reason. If you have hard water in your area, you don't know it, but over time, it gets deposits in the lines. It actually decreases the longevity of your dental unit. People don't talk about that when they're actually doing an office over. And the reason that's important, even though you think you have the same amount of water coming out of your handpiece today as you did 10 years ago, there's a good chance you don't, because the air that's being combined with it makes it look the same to you. But in reality, you have less water, so actually you don't have the same amount of irrigation while you're cutting a prep. And many of us forget that. So we have to keep in mind our burrs and our water, our irrigation, makes a big difference. And of course, trauma, which I really don't need to review, because I think all of us understand that trauma, of course, can cause necrosis. But when we have young children and things, we give it the benefit of the doubt. We know even over 3 months, and with new things that we're doing in revascularization, things can change. And we hope for mineralization and building of tooth structure down there, so we don't have an open apex, but more importantly, we don't have a weak tooth. That's what we're encouraging. Next, irreversible pulpitis. All right, well, how did we get to an irreversible pulpitis? Well, the first thing we probably have to address is something real simple. When Kakahashi did his study in 1965, the second name on that paper was a gentleman named Stanley. Well, you may or may not remember this from your karyology class, but there was a critical paper that was written in 1966, and that was by Reeves. Well, guess what? Who was the second name on that? Stanley. Why is that important? It's Reeves and Stanley that after Stanley knows that it's bugs that cause this, it's Reeves and Stanley that review how far do bacteria penetrate in the tooth and what is their impact on that pulp. And what they found was if bacteria, if caries is 1.1 to 2.4 millimeters away from the pulp, there's no inflammation going on inside. However, what did they see? If you have bacteria in reparative dentin, or if you have caries a 0.5 millimeter or less from the pulp, you have inflammation and you probably have an irreversible pulpitis. So that's why as an endodontist, I have to be honest, I have a little bit of a problem when we always talk about, oh, it's just affected dentin. As far as I'm concerned, there's no such thing as affected, it's infected, okay? We just have to review it and look at it differently. If you want, you can put a Band-Aid on it, hope for a calcific metamorphosis, and then when you can't find the canals later, all scream and say, yeah, take the tooth out. So we have to realize why we're doing endodontics, and sometimes it does become irreversible. And the key thing here is with that irreversible pulpitis, it's that lingering pain as a general rule, but we'll go over that it's not just about irreversible pulpitises that give that lingering pain. There's more to it. Progressive degeneration of the pulp. That's what happens normally after an irreversible pulpitis. And unfortunately, we need to make sure we understand that it's usually accompanied by symptoms. Usually, not always. Also, it can initiate early apical periodontitis, but please never look at this radiograph and think you know everything. We do, however, look at this. This is what we're looking at. We're looking to see the lamina dura. It's CAFE that tells us if you have an intact lamina dura, that's how you judge and actually critique the periradicular tissues. It's not whether or not there's a widened PDL space, whether or not there's a lesion. That doesn't tell us anything. We look at the lamina dura, and that's why we have to take good radiographs. We have an obligation to our patients to take better radiographs. We need to train our assistants on how to take better radiographs. Also, when you look at a radiograph, please do me a favor. When I train my residents and students, I always tell them the best seat in the house is not always on the first base line. Sometimes it's in the bleachers. Because if you're in the bleachers, you start looking at everything. And one of the things I want to remind everybody, you as a dentist, you're a doctor. You're not a lab tech. You may be the first person to tell that patient that I see laddering. You actually might have sickle cell anemia. You have punch-outs. You might have a multiple myeloma. You have to understand the information we're being given. We really do have a lot of information, but don't let anyone be fooled. This is a two-dimensional image, and we work in a three-dimensional world. So we have to make sure we understand that. So the irreversible pulpitis, progressive degeneration, results in complete pulpal necrosis. Now we have pulpal necrosis, and yes, when you have a necrotic pulp, it's more likely that you're going to have infection. Remember, necrotic pulp becomes infected. That's something that's just a fact, okay? It's more likely that this will become infected. And there's many things that we're going to review, but the key for everyone in this room is remember, we took an oath and we have an obligation to our patients to reproduce the chief complaint, to determine the cause, and our goal is to eliminate the cause. We need to do this in a more systematic way. So how do we do that? Through a dynamic diagnosis. It's what medicine does better than we do. A dynamic diagnosis is something that's just not a couple of tests. Of course, we want to develop our diagnostic findings because we all know the importance of soap, which I'll go over. But we have to make sure that when we go through this, we derive a provisional diagnosis. And what do I mean by that? Never tell Junior's mother or father that all they need is an MO or a DO or an MOD, because we all know until we pick up that handpiece, we might not know when that individual is going to require a root canal. Because once you pick up that handpiece, you might find that the caries actually is into the pulp. So remember, in the beginning, when we do our test, we're just deriving a provisional diagnosis. We're not really coming up with a final diagnosis. That's part of understanding the dynamic diagnosis. It's taking these pieces of the puzzle, bringing them together, assessing them, and coming up with a plan of treatment. Next, we continue observation. Some cases, we should not be doing a root canal that day. Sometimes we want to follow it up. And of course, continue collection of significant data. But in order for us to derive a final diagnosis, it may require us waiting till after treatment or after a 1-year recall. Remember, your diagnosis can change all the time. What happens if you had a perfect diagnosis and you say, this was an irreversible pulpitis, I had a symptomatic apical periodontitis, I did the root canal, I did my core, I did my crown, and the tooth was extracted 6 months later? Your diagnosis might have been wrong. Your diagnosis was good. However, it may have been a fracture all along. The dynamic diagnosis is something we need to embrace. And as soon as we do, you'll see that the outcomes of endodontics is even higher than you think they are. That's a great point. Now, I will tell you that many of us know that the best thing you can do for the patient is make sure you have a healthy pulp and restore it to function. But the bottom line is, if you do a crown prep, my personal, this is empirical, but I'm telling you data that I am pulling from Axiom, which is our electronic health record, and I've been pulling it since 2006, and there's some things that get checked off in the chart. And one of the things that I'm seeing and I'm extracting from that data is, we have them transilluminate their crown prep. And whenever they check off the box that they say that they think they may have or do see a pinkish hue, it's really funny how I would tell you that about 75 to 80% of them always end up with non-surgical endodontic therapy. So that's another issue. And then, there's the issue of, how much tooth structure are we removing, and is that too much? But overall, it's a great point, but I would tell you that maybe sometimes we need to make sure our temporaries have better seals, and maybe we shouldn't push it right to that final restoration when we're not doing endodontic therapy, when we have more tooth structure. And that's something that all of us, I know it's a tough one, but that's maybe something we need to evaluate together and make sure that we're not just doing a crown and saying, yeah, if you need a root canal, we'll go through the crown. Because Abbott says remove all restorations, even if it's only a couple months old. Yeah, absolutely, after a trauma. Oh, absolutely. Let me rephrase it, though, because you brought up a good point. Yes, that is a necrotic tooth, but the problem is there's some terms that we haven't gone over yet. And one of the things the ABE and the AAE, Gutman, Gluskin, Walton, sorry if I'm leaving anybody out, when they got together and did their review and came up with the new terms, one of the big changes was we, as a room, are used to hearing irreversible pulpitis. I put cold on it, oh, they raised their hand, it's lingering, you can see it in their face. No more. There's two types of irreversible pulpitis, symptomatic and asymptomatic. An asymptomatic irreversible pulpitis, just one example, could be Junior who fell off his bicycle, and I actually was hoping that after 2 or 3 months that tooth can become responsive. It didn't. It all along was an asymptomatic irreversible pulpitis. It was going, okay? So there's different ways to read it.
When you say it was going, what happens when you see Junior 30 years later with no treatment?
It may, in his case, never became infected. If the tooth wasn't moved from its socket, bacteria didn't get around, or there wasn't a periodontal communication, for example, a Perio endo lesion described by Simon, Glick, and Frank, where you have a primary perio, secondary endo. There's all different ways the canal can become infected and bacteria can enter in through fracture, through trauma, through obviously lateral canals. So there's different ways that bugs can get in there. But you can have trauma, have a necrotic pulp, and you may see discoloration, but overall you don't ever see an infection. And the crazy thing is sometimes you'll even see a lamina dura that's perfectly intact, but the mom's not happy with the tooth color. And then that happens, as we all know. So it doesn't have to become infected, but it is more likely that that necrotic pulp is going to be infected. And we know that just because of the fact that endodontic therapy is normally caused by bacteria. We know that from Kakahashi.
Is it proper or improper to treat that tooth if it's asymptomatic and there is no complaints by the patient?
Well, I'll throw it a different way. If we tested everybody in this room, I guarantee that we probably have, out of every tooth, everyone's teeth in this room, I'll guarantee you we have probably 5 to 8% of the teeth that have no response. Should we do root canals on all of them? Simple answer. If you have an intact lamina dura, you have no periradicular inflammation, the patient's not complaining about percussion, palpation, and you have an intact lamina dura, you can do a veneer on that. You can do a jacket. Absolutely. Okay? So we have to start thinking dynamic diagnosis and when to retain the tooth. And I know it sounds funny, and it still is to this day the #1 framework used in diagnosis in both medicine and dentistry. It's SOAP. But I want to introduce something in a different way. When I talk to the residents, I always remind the residents that, yes, it's SOAP, and everyone in this room right now is going, oh gosh, he's still talking about diagnosis. But I want you to remember something. This is why you're doing dentistry. And I want to tell you the real formula that I tell the residents. Subjective plus objective information equals assessment and plan of treatment. It's the result of this subjective and objective information that you're bringing together that you can assess with radiographs that give you treatment planning options. See, SOAP is really from A to Z. It's your treatment options being established. And one of those may be nothing because from all your tests you found out this patient doesn't require any treatment today. So it's subjective plus objective equals assessment plus plan of treatment. One of the things we have to do is ask the patient what's bothering. We need to know the chief complaint. My favorite line, what problem can I help you with today? Look, they're not in my chair unless they have a problem. I never walk up and go, hi, how are you? Is there anything wrong? You're not here to see me if there's nothing wrong. Now, I will admit, even though they're my friends, many of my friends will send a patient and say, Dr. Bruder will determine whether or not you need a root canal. I look at the radiograph, I'm like, really? Why am I always the one carrying the sickle? Can you just tell them they need the root canal? I know you've even done the test, but you want me to be the one to tell them. Because when you go back and have the crown done, it's a result of me. It's not because of you. Okay? So the main thing we have to do is we have to realize that this patient's here for a reason. So please do me a favor. It takes 2 seconds. Ask the patient, what problem can I help you with today? And then no matter what they tell you, write it in the chart. I have a toothache. I want it in your chart. As someone who reviews cases, please do me a favor, have a chief complaint. There's a reason we're doing it. There's only one thing I want to remind you of. There was a great study by an individual named Friend. Friend showed that patients are only accurate 33% of the time at determining and diagnosing themselves, even when they're pointing to a tooth. So remember that patients are not accurate at diagnosing themselves. Okay? Next, medical history. We all have to get better at medical histories, okay? Everyone in this room needs to get better at medical histories. But now I want to share something with you. I told you earlier, I only have a day and a half a week in faculty practice. Yes, it's from 7 a.m. to 7 p.m. on Monday with a half-hour lunch, and on Wednesday I go from 12 to 8, but I want you to know something. I've learned to become efficient. And one of the things I want to tell you is if you are designing a new office, or if you ever have in your life, you realize that the most expensive square footage in that office is the operatory. It's just like when you build a house. The most expensive square footage in a house when you're building one is the kitchen and the bathrooms. Well, when you're building an office, the most expensive square footage is the operatory. Then please answer a question for me. And I'm just an educator. Why do people allow patients to sit in their operatory and sit there and fill out medical histories? If you have a new patient coming in or a patient that hasn't updated their medical history in over a year, your front desk, even though that patient has a 10 a.m. appointment, they should be booked at 9:45. Because there was a study that was published in the New England Journal of Medicine that showed patients are more accurate when they fill out a medical history in the waiting room away from the physician than in the physician's chair in front of the physician. I actually have a theory why that's true. Because patients have smartphones, and if they don't know what the drug is, they look it up in their smartphone. If they know they have something, they actually will look it up to make sure they have the right spelling, so then they actually put it down. I really think that's the reason. And when you're not there, they're actually more likely to go through their smartphone, which may even have all their drugs. So that's something to keep in mind. Have the patient fill out the medical history in the waiting room, because we're doctors. We should be reviewing systems in the chair and doing updates to their drugs and reviewing systems every time they sit in our chair. Keep that in mind. Subjective information. I want everyone here to understand that when we talk about subjective information, we're really talking about these 8 things. We want to find out from the patient. The subjective information the patient's going to give us includes history of pain, stimulus of pain, the severity of the pain, and of course frequency of pain. These 4 you should actually find out from the patient. They should be able to just rattle this off. When they're telling you their chief complaint, they should start talking about this. If they don't give you a history of the pain, you need to ask for it. But when we look at this side, I need to know the duration. How long has this been going on? Seriously, how long does it last? What's the location? Why is that important? We'll go over it more. But remember, 90+% of the time, pain never crosses the midline. You want to know the location of the pain, or at least the way the patient sees that pain. We have to get a better read on where. The spontaneity of the pain. What causes this pain? Is it spontaneous? Is it because you're laying down? Oh, wow, I just realized my cardiovascular output. Why do they feel that throbbing? Think of it. We all went through physiology. Of course they're going to. Their cardiac output's changing. And of course, nature of pain. Nature of pain is the best way you can tell whether or not a patient is seeking drugs. Nature of pain is the hardest thing for a patient. Nature of pain means that the patient has to describe the pain to you. Nature of pain is the hardest thing for someone who's seeking drugs to fool you on, because no one can actually tell you how pain feels. None of us in this room can feel pain. Even if we've broken an arm in our life, we cannot feel that today. That's our defense system in our head so we don't go crazy. The reason I know this is true, I was there in the delivery room when Dina gave birth to our twin boys. I was there. I know what she went through. There is no way the woman that I love gave birth to the twin boys, and 1 year later, knowing her pain, would ever ask me if we should try to have a girl. Okay? There's no way she can remember that pain. Okay? So that's a defense mechanism we have, but it's something we have to remember. It's actually something really good for us. So we have to throw the next snake on the table. When we talk about pre-medication and we're talking about our medical histories, we all have to remember that there's been a lot of controversy. Well, I want to help end it for you. In 2009, the American Academy of Orthopedic Surgeons got together. And at their annual session, they made a statement. Now, unfortunately, it got a lot of press. Guidelines for patients who have a total joint replacement were updated by the American Academy of Orthopedic Surgeons, AOS, in 2009. Let me tell you the real reason why they did it. They said, given the potential adverse outcomes and the cost of treating an infected joint replacement, the AOS recommends that clinicians consider antibiotic prophylaxis for all total joint replacement patients prior to any invasive procedures that may cause bacteremia. Well, that's not evidence-based. And the truth is, we all know that recently there was an article written by the ADA in conjunction with the American Academy of Orthopedic Surgeons that really said that we don't have to actually pre-medicate these patients anymore. But one of the things I want to remind everybody is, if you have a patient and they recently did have a hip replacement, you should reach out to the orthopedic surgeon and ask them what their thoughts are. And I know many of you are going to say, well, you know what, they never want to commit. Well, you want to be part of a team. Okay? You want to make sure you also help yourself and your patients. So make sure you reach out to the orthopedic surgeon. And the reason I bring that up is, I know we have to pre-medicate certain patients, but I'm not sure what we'll be doing in 10, 15 years, because I was really lucky. Much of the work I did when I was at Harvard was in Sig Sokransky's lab at Forsyth, the father of checkerboard hybridization. And you know what? Sokransky used to quote a lot of stuff just walking through the halls. And if you listened, you learned a lot. And I can always remember sometimes him throwing across the bow saying, do people just forget all about Fleming? Fleming is the person who discovered penicillin. And what did Fleming himself say? Fleming himself said, too little or too short a period. That's one of the biggest problems we're going to have with antibiotics. That was Fleming himself. So guess what? Every time we pre-medicate a person, unfortunately, it's too little and it's for too short a period of time. But I'm not telling you to stop pre-medicating. I'm just identifying a potential problem we have. Yes?
Do they really have to pre-medicate
Absolutely, it's an invasive. I'll just say it two ways. One, no matter what anyone says, when we give an injection, it's invasive. But the other thing is, it always makes me laugh a little bit when people say, I can't believe you advocate and your family tree advocates patency. Everyone in this room, every one of you get patency, because not one of you have ever kept the file inside the confines of that tooth and completed the root canal. Because when you're trying to establish your working length, I guarantee you've gone long. Because if you think the radiographic apex is the real thing, you're wrong. If you think your estimated working length is correct every time, you're wrong. So the truth is, we are invasive. And depending on what tooth we're working on, we may be more invasive than others. So it's something we have to understand, and that's something we have to take serious, okay? One of the things we have to examine is how we review data. Our clinical examination. It's an extraoral and an intraoral exam. Well, I learned a lesson a long time ago. I love my mentor, but there were some things that I wish I could have done without. I'll tell the story. It's a little embarrassing, but hopefully you'll understand why I do the things I do. When I walk into a patient's operatory, I do something very important. He right now is so uncomfortable, you have no idea. When I walk into an operatory, the first thing I do, I say, how you doing? My name's Dr. Bruder. What's yours?
Hans.
Hi, Hans. Pleasure to meet you. All right, first of all, I love my assistants, but now I know Hans is the right patient in the chair, okay? Don't say you've never had that happen in your life, okay? But now I know Hans is in the chair. But the truth is, when Hans was talking, there were a few things I was looking for. Now, it's a little difficult to go out on the edge in the cliff and say that, you know, I'm looking to see if he has a fibrous connective tissue disorder or something. But you know what? I am really looking to see how he opens up. I'm looking to see if he's symmetrical. I'm trying to see if there's any problems. Is there anything that I should note? Is the jaw deviating? Because I see a lot of trauma. So my exam started at my introduction, and it doesn't take me any extra time. But I also connect it with the patient, because patients want you to look them in the eyes. And unfortunately, a lot of us don't even look our patients in the eyes anymore, and we don't even realize it. We need to know that that's a patient that came to see us and they trust us. So when we start our exam, it has to be an extraoral exam. And I always start palpating. Our intraoral examination, please. If a patient comes in and they go, I can't touch this tooth, doc, please. An intraoral examination can be very simple. After you review the medical history, ask the patient what the chief complaint is, their dental history. What's wrong with starting your palpation with your finger? If a patient can't touch a tooth, why do we have to take a mirror handle, flip it upside down, and bang on it? They can't touch it with their finger, okay? So there's a lot of things we can get done early on that really only take a few seconds. Next, radiographic assessment, our comparative testing. We need to get better at our comparative testing, and we're going to discuss that today. But in order to do this, I want to make everyone here more efficient. People always ask me, I'm not going to lie to you, people always ask me, how do I get quicker? I'm the wrong person to ask that question. I'm an educator. The last word I want to hear is quick. I want people to become more efficient so they can actually do better endodontic therapy, and my profession and my specialty can have better outcomes, and patients can be treated and not in pain. And the first thing we need to do is we need to start here. This is the #1 problem in dental offices across the country. My gift to my residents when they graduate is, when you set up a brand new office, after you've been there a month, I come and shadow you for 2 days and I give you a report of what I see. The way your front desk is talking to patients, if you're running with an emergency, did they get up and tell the people in the waiting room that I'm sorry, the doctor's running about 20 minutes late, but it's because of an emergency, and I promise you, he'll be with you shortly. If you don't tell the patient, they're just getting angry. If you tell a patient there's somebody that's in pain and it's an emergency, patients understand, because they know if that was them, they wish that you would do the same for them. We need to make sure that we work as a team, but this is part of it. And yours obviously can look prettier, but the truth is, how many people here can say that when they have an emergency in their office, their assistants know where to go and grab a tray and it's down within 10 seconds? If not, you're not efficient. You should never put gloves on and rifle through drawers in front of patients. 1, it's contamination. 2, it's a bad thing that patients see every single day. And if you're going to really take this serious, you should go back and spend 15, 20 minutes with your assistants. Set up a tray and take a photo. And have an area where you have them all in plastic, even if it's a book, on what the setups look like. That's how you become more efficient. It cracks me up on what people spend for office management software and all this, but the truth is, when it comes to the treatment, they're still lost. We have to be prepared for treatment. If you fail to prepare, you prepare to fail. So please, get back to your office and understand what's going on here. My basic kit for treatment or diagnosis is this: 2 Q-tips, cotton pellets, 2x2s, cotton rolls, a mirror college plier, normally a glick or something, a plastic instrument, a Perio probe, and an explorer. But don't ever forget this guy right over here. That's a tooth sleuth, and I'll go over it. Next, some type of frigidant, whether it's frigidant or endo ice. Endo ice obviously is a lot less expensive than frigidant. But if you're trying to go through a crown, it's one option, but I'll give you another option. And then even though people kind of forgot about this guy, an EPT. And why? It goes back to 2-3 years ago. Andresen and Backlund told everybody that even though we didn't in the past, when we have trauma cases, one of the things we can do is start using an EPT again, because now we can quantitatively obtain information. And that way we can tell in our chart what the setting was and what the number was before that tooth responded, if it responded at all. So now it's becoming more quantitative. So that's extremely important. Next, when we talk about palpation, I know many of you have been practicing for 20+ years, but we have to take palpation more serious. And how do we do it? Yes, you can use your finger, but if a patient comes in and they point to tooth number 9 and they go, oh, this tooth here, the last thing I want you to do is start on tooth number 9. So I'm going to give you a couple tips. When you have an anterior tooth, always remember that approximately 90+% of the time, pain cannot cross the midline. If it does, you have to start thinking non-odontogenic or oral path, period. Next, if you have a central, lateral, or canine, never, ever, ever, especially if it's central or lateral, start at that canine. Why? Real simple. Canine eminence, thinnest oral mucosa in the mouth. Common place for a fenestration. If you palpate there, the patient might say that that's sensitive, but that's a false positive because that tooth might respond completely normal and it's a healthy tooth. So don't get caught. My favorite place when it's a central or lateral to train is back here. I tell my residents to always start at the maxillary first premolar. I have my residents, unless it's a premolar for all teeth, anterior or posterior, they always start at the maxillary first premolar. Why? The buccal root of the maxillary first premolar is the farthest from the sinus. It's least likely at any time of year to give me a false positive for a sinus infection. So I always have them start there. My favorite tooth for starting my test is the maxillary first premolar and work myself anteriorly or posteriorly, except if they actually point to the premolar region. Okay? So keep that in mind. When we're doing this, we need to understand the anatomy and why we do the things we do. Next, if we're just going to have some tips that we all need to remember, we need to remember this one right here. Every one of us, when we were in school, we all remembered, okay, Branstrom. We all remember the hydrodynamic theory. We have to remember that fluid moves all the time. We have to remember something, though. Unlike everything else in our universe, when you add energy or heat, things expand, not teeth. You have to remember that the reason a patient sometimes comes into your office sipping cold water or chewing ice, it's because when you have heat on a tooth in certain conditions, what's happening? Fluids are going in instead of out. That pressure, that's your problem. So by them sipping cold, they're changing the gradient. That, in a nutshell, the watered down version, that's really what's happening. That's why they're sipping water or chewing ice. They're relieving that. So we need to remember, why would you ever take an air water syringe and dry off a tooth? If you have dentin sensitivity, yeah, that's going to cause a stimulus. You don't know what the positive is now. That might be a false positive you can't get rid of. If they have recession, dentin sensitivity, toothbrush abrasion. So whenever you're going to do a test, please take cotton rolls, put them in the vestibule, take a 2x2, and dry the teeth with that 2x2. Now you want to perform your test. And then the key thing is, as I always tell my residents, please stop doing the old trick of, oh, please open up, and if you feel something, raise your hand. Okay, we explain what we're going to do to the patient prior to actually doing the test. It's always fun to watch dental students and residents describe a procedure as they're doing the procedure. So please, isolate with cotton rolls, dry it with 2x2s. Take a cotton pellet, spray your endo ice on it, and then apply it to the tooth. So let's talk about that for a second. If you're going to use cold, yes, there's a million ways you can do it. And you've all heard about freezing ice inside the, the anesthesia carpule tops. But the truth is, I like to use endo ice. Now, if I have a crown, yes, I will use Frigident. Frigident is approximately 2 or 3 times more expensive, but here's a couple tips. 1, if you have an individual that you think is responding to every test you do, even though there's no response, just they're hypersensitive, they're nervous. An example, a child. How many times have you actually put cold on a tooth that's unrelated to the child's problem and they jump out of the chair? See, that's because they're nervous. And also, they have an audience. It's normally mom or dad. Here's an easy trick for everybody in the room. Whenever you do cold testing, whether it's a child or an adult, always, always hold your cotton plier with your cotton pellet and put your cold on it from behind them. The patient's normally at 10 or 12 o'clock for me. I always do it behind the patient. Why? If I think Junior's acting up that day, I do one of these. They don't know it, but I never even sprayed cold on the Q-tip or on that cotton pellet. And now I put him on the tooth, and if he acts up, I turn to mom and dad and go, I think you need to leave. And then I have a talk with Junior, say nothing was even wrong with that. And I'll put it on them as it's room temperature. There's no cold at all. So an easy trick for you is to always do the cold behind the patient. So if you need to modify your test, you can simply just turn it away and spray it. They still hear the noise, so they think it's going to be cold, and that's why they're responding. So it's an easy trick for everyone. Now, what if you only have endo ice in the office? Okay, really simple. If you have a crown and you're trying to penetrate through, you need more cold. Now, it's going to use a little bit more endo ice, but it doesn't make you go out and buy Frigident and endo ice. Easy trick, everybody. Shake the can, turn the can upside down. When you turn it upside down and spray it, it's going to be 3 times colder. You will see a frost on the cotton plier. You only have to do me one favor. Your cotton plier and cotton pellet are at room temperature. When you freeze it that much, there's going to be condensation. As you come up to put it in the patient's mouth, go like this and shake off that condensation so you don't get a false positive by the drip on the soft tissue. It's an easy trick, just shake it off real fast. Okay? Next, heat test. Now, I could close my eyes and make believe that I don't know the result to this question, but this is something for all of you to get a good chuckle out of. Ready? I'm going to close my eyes. How many people in this room, patient presents to the office, chief complaint is heat sensitivity. How many people in this room in the last year have heat tested a tooth? Yeah, real surprise in the answer, huh? Okay, so now I've identified an endodontist. Okay, so the truth is we have to realize that we have to reproduce the patient's chief complaint. We have an obligation, okay? But there's some rules. No matter how you're doing it, okay, and at our school we use the heat tip with gutta percha in it, but there's something I want you to do. Whether you're using green or gray stick compound or heated gutta percha, please do me a big favor. When a patient is in pain and they're heat sensitive, the last thing you want to do is put something that's hot on that tooth and not be able to get it off. And pretty much everything in dentistry that we heat up becomes sticky, okay? And if you put hot gutta percha, gray or green stick compound on a tooth, and they actually raise their hand and you can't get it off and you feel the need to put your knee on their chest to get it off, it's not going to be a big practice builder. They're probably not going to be happy with you at the end of the procedure. So it's an easy trick. Take a little bit of Vaseline, and all I want you to do is put a small dab of Vaseline right there. That's going to conduct the heat in, and it's going to be your break point. Just do me a big favor. I've been doing this a long time, longer than you think. Do not take the Vaseline and get it on the soft tissue. You know, it's funny that you would have to explain that to a dental student, that if you're heating this up, that it might actually fry the gingiva. So please, do me a big favor. If you are going to use the Vaseline, just make sure you don't get it on the soft tissue, because when you heat it up, you might have a patient with a 2nd-degree burn the next day. Okay? So what we want to do is just put a small dab here, and that's our break point, so it actually comes off the tooth. So in review, percussion and palpation, start with uninvolved teeth. My favorite, as I said earlier, maxillary first premolar. Buccal root, farthest from the sinus, less false positives. Get the patient accustomed to normal. Work towards a suspected tooth. Make them understand that you're doing this to help them. Next, perio probing. Record all depth measurements. You have to perio probe teeth. It's going to help us determine whether or not this tooth is fractured or if there's something else going on. Mobility, I'm going to discuss that in a moment. And of course, images. I don't care if you work with your uncle, your aunt, your father, your mother, they have to be current. If someone saw a patient for an emergency and you're seeing them for the first time, you should take your own radiograph. You don't know what was done to that tooth. You don't want to take responsibility for something that you didn't do. Perio probing, we have to get better at our probing depths. We have to understand that right now I can gain a lot of information. Not only can I find out about the soft tissue and the hard tissue, but I might be able to realize if this tooth is rotated, especially if there's a crown. Because if there's a crown on the tooth, and I start always from the mesial buccal corner, if I'm probing from the mesial buccal corner, and as I'm probing, all of a sudden my probe comes all the way palatal, there's a good chance that that tooth is rotated. If I'm probing from mesial buccal to distal buccal and the probe comes buccal, there's a good chance that the tooth is rotated this way. I come under the cervical bulge and I very lightly probe. And I just repeat it on the palatal side prior to putting on my rubber dam clamp. When we talk about furcation, we have to note when there's a furcation involvement. The easiest one, and I'm an endodontist, the easiest one for me is GLICKMAN. All you have to do is remember 4 things. When we talk about furcation involvement, I want everyone to remember that a class 1 is an incipient lesion. Class 2, you're driving your car and you hit a dead-end street, and at the end of the dead-end street there's a cul-de-sac. You can't go through the houses at the end of the cul-de-sac, so you have to turn around and come back out. There's a solid mass at the end of that. You cannot go through. Class 3 and Class 4 are actually really, really simple. A Class 3 is through and through. A Class 4 is through and through. Here's the difference. A Class 3 is occluded by gingiva. That's your main thing that you want to remember. A Class 3 is occluded by gingiva. A Class 4 is a tunnel. You can go right through it. And we need to remember that. Now, we have to remember that the reason we're checking things like this is sometimes we have perio-endo lesions. And I'm not trying to show you extreme cases. I'm trying to show you cases that happen all the time. This is actually a really, really good friend of mine's wife. Unfortunately, had to go through a lot of medical treatment. We have no idea to this day. He's a periodontist. He was keeping her clean, literally coming into his office every 2 to 3 weeks throughout her treatment. We have no idea to this day why she had an isolated blowout. And when he asked me to do the root canal because she was still in the middle of the treatment, we found out after operation that she had a perio, primary perio, secondary endo lesion. And we did kid around, and he said, George, just do me a favor, do the endo. I know you're going to laugh, but just make it a space maintainer. Truth is, she still has it 5 years later. He hasn't taken it out. This one here, we see a lot of things at Stony Brook, and many of you probably know that some of the biggest studies that ever came out on bisphosphonates came out of LIJ Stony Brook because that's Sal Ruggiero. Well, I see those cases all the time, and one of the things I saw is this one right here. No one wanted to touch this patient, okay? And everyone was like, no way are we extracting this tooth right now. In the middle of radiation where Marks would have had her in a hyperbaric chamber for a month, and obvious IV bisphosphonates. Well, the problem is, I saw the patient, opened it up, instrumented, put calcium hydroxide. Patient disappeared for 9 months. You can't make this stuff up. Patient comes back 9 months later, all the bone fills in. I'd say that that's a perio-endo lesion if I ever saw one. So we need to work together as a team, and we have to understand that the most important thing about perio-endo lesions are these 3 guys right here. And unfortunately, if you didn't know it, we just recently lost Dr. Simon at USC. And that's why I put this slide back in, because we have now lost Simon, Glick, and Frank. And I really adored Dr. Simon. I was just there in the fall doing the surgical lecture for his resident, so that actually sort of touches me. So I want you to remember, they were the ones that talked about primary perio with secondary endo lesions, primary endo with secondary perio lesions. That's where it comes from, perio-endo lesions.
Excuse me, I want to go back to your heat test one more time.
Sure.
That's something we don't do on a daily basis.
Right.
Patient comes in complaining, I'm having a cup of coffee, I feel pain. One question is, before you go to your heated compound, would you give a patient a cup of warm water to rinse with so you can pinpoint the tooth?
See, that's a great point. I just want you to remember that the body is a fun thing, and the way signals get to the cortex and the way we have referred pain, having them just slosh around warm water, it's great if you have a patient that there's only one tooth involved. But how many times do we actually have a patient with multiple problems? And by doing that, you are going to find out that, yes, they have pain to heat, but I won't put any real weight on which tooth by just doing that.
I mean, just the prerequisite to get the compound, because the compound is pretty hot. You don't want to put it on every single tooth before you go in there. And how much would you heat the compound? Would you have it?
You guys have a bath. It's the easiest thing in the world. You actually have a big advantage. I would run it right in a bath. I do warm gutta percha. I have a device that actually, I put a gutta percha cone in reverse, and I cut off the tip. I leave about 2-3 millimeters sticking out. I heat it up. There's even a preset button for heat testing, and then I put it on the tooth after I put Vaseline. That's really accurate, and I like it because of the angle, so I'm not worried about hitting soft tissue, even though I've isolated it with cotton rolls. But when you're doing your compound, one little trick, and I maybe should have said this earlier, an easy trick is take your compound, run it through a bath, and then put it onto a glass slab, roll it real quick and make a point, and then take a Woodson and cut through, and then have yourself a little point at the end. Dip that in the bath one more time and then put it right on the tooth. Okay? Because that way you have an angle, it's smaller, you're not taking the whole compound trying to come in on an angle. It's just an easy way of coming in on an angle with it. Okay?
You talk about like FURCATION involvements. And
yeah.
Some of these older patients have had this, massive perio surgeries that we don't do anymore. We don't see anymore. But they may have teeth with, FURCATION, molars and everything like that.
Exposed roots.
Now it's exposed. Is the standard of care now? You were saying with these FURCATION, you don't do an endo?
No. No, you know, that's a great question. I just want to say something that I always tell the residents. We as dentists, unfortunately, when we were being trained, we heard this term, ideal treatment plan. And the truth is, there's no such thing. Because your ideal treatment plan is not the same as yours. And I'm talking about not them to a patient, but what's going to be done on them. And I'm going to say another thing. An ideal treatment plan for anyone sitting in this room as a dentist is not the same as a patient on limited resources. Because we know that we might tell a patient, oh, take the tooth out and do this, blah, 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 or let's just, do X, Y, Z. We'll put this, 5-surface restoration on it. If it was you, you would never do that to yourself. And how many times would we not extract a tooth on ourselves, even though we're telling a patient to extract it? We have to remember that, ideal treatment plans are something that are independent, and it's patient, dependent, because we have resources as, clinicians, as dentists, that the average patient doesn't. But no, should every tooth that has a FURCATION involvement be extracted? Absolutely not, because we have medical complications, we have numerous things, and many oral surgeons will tell you, I'm not touching this tooth.
What I'm talking about is, how does that go by the standard of care? In other words, can a patient...
That's not a standard of care. There's no standard of care that says you have to extract the tooth with a FURCATION involvement. There's absolutely nothing that's even remotely close to that in a standard of care. I know this sounds funny, but there really aren't a lot of standard of cares. People don't realize that, and the reason is because you would never make a standard of care as an organization, the ADA, if you feel that somewhere there's going to be an American in a tent being treated by a military doctor, and it's not the same as being treated on Park Avenue. So you can't make it a standard of care, because then you're saying your soldiers are receiving treatment below the standard of care. Hate to put it that way, but that's reality. And that's something we all need to remember is standard of care is overused. I gave you one this morning, but there really aren't as many standard of care as you think. I would say it's practicing below standards, okay? Yes, I would say it is below the standard of care and actually illegal for an individual in Oklahoma to be an oral surgeon and not sterilizing their instruments. Hypothetically, that could happen, okay? I mean, I think everyone here, if I would have given that scenario 6 months ago, you would all laugh me out of the room. Who would have ever thought, okay? And this is someone that, I'm not even going to porians, and I'm not even going to micro, at the micro level. I'm just talking about, that's common sense. So that's something we all have to think about. It's a great point, but it's not below the standard of care to keep a tooth and try to maintain, and that's a better way of saying it, to maintain a tooth. And the reason you know it's not a standard of care, they would have never made brushes to clean them out. Because companies do studies to see how many teeth have something when they forecast a product. If they can't sell it, they're not going to make it. Okay? But to your point, there's a lot of patients that were treated certain ways in the past by the Adam Bears of the world, the Goldhabers of the world. We all know the Cohens of the world. We all know that. And I'm not saying that was the wrong treatment at all. And as an endodontist, I'm definitely not. It would be interesting to find someone doing a root amp nowadays, but that's a different story. So we have to identify the importance of perio-endo lesions. One of the things I want to share with you is one of the courses I took by somebody I mentioned earlier. Great point, and I would love to have your feedback here. I was sitting at a course by a leading prosthodontist, and I was reminded of something. that 90 to 95% of the teeth that every one of us in this room diagnose as being mobile, it's a direct result of trauma from occlusion, even though it's secondary perio now. And that's something that we all have to remember. That's something we all have to remember. That is extremely important, and how we determine whether or not that tooth is mobile is another thing. Every one of us have to get better at classifying these. We should actually write that in the chart. We need to determine whether or not we have a Miller classification 1, and the way I teach my residents is really simple. I always tell the residents, yes, we could talk about a 1/2 millimeter buccal, 1/2 millimeter lingual, but I want you to remember it when you're in the clinic or with that patient. Easy way. Class 1, 1 millimeter or less movement buccal lingually total. Class 2, 2 millimeters or less movement buccal lingually total. Class 3 is the only one you really have to remember. It's greater than 2 millimeters total movement. But I want you also to recognize this one here, class 3 can be depressible in the socket. I want you to remember that if it's depressible in the socket following an immediate trauma, that's one thing, and I may try to stabilize it. However, it's always funny when a resident comes up to me and they're like, hey doc, it's a class 3 mobility, but they really want to try to save the tooth. History of trauma? Well, from occlusion, but no traumatic injury per se. And I'm like, and it's a true class 3. And I'm like, and they're like, yes, but they want to save it. And I look at them and I'm like, and what are you going to do? And the first thing they say to me is, I'm going to isolate the tooth. Well, I hate to say this has really happened 2 years ago. My resident comes back in 30 seconds and I'm sitting there as they walk out of the operatory and I'm shaking my head. They're like, you didn't even come to my operatory. How do you know what happened? And I'm like, I knew exactly what you were going to do. You did single tooth isolation. You just extracted the tooth with a rubber dam clamp. And they're like, yeah, I did. All right, that's not something to be proud of as a resident, but yes, they did give a free extraction. Next, exposed dent. Please remember not to blow air when you're drying teeth. Because if you have exposed dent, you're going to get a false positive. The great news is, if you read a paper that was done by Abbott, he talks about the fact that most of the time when you have exposed dentin because of dentin sensitivity, when you blow it on that tooth, it reacts and it immediately goes away. That's the great thing about exposed dentin, dentin sensitivity. It's normally a reaction that goes away immediately following you removing that irritant, such as air. So keep that in mind when you're trying to diagnose as well. Next, we have to look at the occlusion better. When we're treatment planning patients, we need to look at what's going on. What happens if this is your patient, you've had them for 10 years, and you just noticed this? You've got to start asking them, did you have a change in job? Are you now grinding? Are you under stress? What changed for this patient? Or was there a tooth extracted on the other side that just changed their entire occlusion, which we all remember those fun cases. It's the domino effect. You remove one tooth, and all of a sudden, the entire bite starts collapsing. They're always fun to fix. Restorability is extremely important, and we have to understand just because it has tooth structure doesn't mean we can always restore it. Sometimes there's fractures that are beyond our control. Not all fractures have to be extracted. However, we have to get better at identifying fractures. And one of the things you can do is go to the AE.org website and download this here, Colleagues for Excellence, Cracking the Cracked Tooth Code by Rivera and Walton. It describes the 5 types of fractures. I recommend this to everybody in the room. The thing that people are still missing every day in their practice is proper diagnosis of fractures. From a craze line to a split tooth. We have to get better at identifying these, and I know all of you will in the future. Remember, post-endodontic disease is one of my biggest problems. Why are we doing the endo over, or why is it failing? Is it because a post was put in it? Is it an active post, or did they fail to recognize all the morphology and treat the entire tooth? Post-treatment disease is something we have to identify and move towards curing. Tooth fractures. Huh? Cracking the Cracked Tooth Code by Walton and Rivera. Next, we have to remember that we would all love to have a patient come in and see this. But typically when you're probing, when you have a fracture, you'll have 2-3, 2-3, and then you get that drop off of the 8, 10, 12. That's something that we note, but that's not going to tell us we definitely have a fracture. Sometimes, okay, we have to review the restorative when we're making that diagnosis. A great line I heard by the same prosthodontist that I mentioned earlier, we should not be doing crown reduction and seeing the top of the post. We have to remember that Some major prosthodontists have commented on the fact that you should have at least 0.75 to a millimeter from the top of your post to your occlusal reduction when making crowns. Why? Because if you have at least 0.75 to a millimeter of restorative material above the crown, the load is being distributed, even if the crown slightly is moving, even though you don't realize, because none of us have any crowns that have moved. But the bottom line is you don't want direct force on that post, even if you think it's being distributed. And even though we know that our retention is coming from the ferrule, you don't want that because that is a wedge. And I hate to say this, dentin does flex, but it eventually gives out. We need to remember that we don't want that dentin being flexed. We don't want it to give out. We don't want a fracture. So you should never complete your crown prep and see the top of that post. And even if it's between visits where you're doing a core and for some reason don't think you have time to reduce it, you should never see a post like that in a patient for years. You should never see a patient in your office walk in with a post being exposed because they're more risk for a fracture. And that's something you should note when you're doing your diagnosis. Next, bite test. Extremely important. The only problem is people continue to use saliva ejectors and moistened cotton rolls. Here's the problem. When you use a cotton roll or a saliva ejector, you are distributing the force across the entire occlusal table and sometimes multiple teeth. The key here is how do we isolate? The best thing I can tell you is a 2-sleuth. A 2-sleuth goes approximately for $20 for a 4-pack, so about $5 a piece. The great news is it's a pyramid with a wedge, it's autoclavable, and it should be in every one of your basic kits. It should be in every endo kit and every basic kit in your office. $20 for 4 of them when they're on sale. There's no reason why you don't have them. And they're autoclavable. They're not a disposable. Why is it so important? Like I said, the saliva ejector and the moistened cotton roll are going to distribute the forces across the entire occlusal table. They're also going to sometimes hit multiple teeth. When you use a 2-sleuth, you can isolate the individual cusp. And what are we looking for? We're looking for that patient to bite down, and as many of us know, many patients have more pain on release when there's a fracture. And there are numerous theories out there really why it's occurring. One theory I sort of go towards is that when they're biting down, it's slightly opening up, and when they release, it's coming back together. Some say it's the fibers on the outside, some say it's the gradient change through the actual tooth. So just keep that in mind, it's one or the other. Transillumination, everyone in this room can do transillumination. I want everyone in this room to understand that if you have a fiber optic in your office, you can do transillumination. Take the handpiece, take the high-speed handpiece off of it. What I want you to do is go to your rheostat and turn the water off. Turn the water off your rheostat, point it away from the patient, hit the foot pedal, and let your foot off the foot pedal. Depending on your manufacturer, that light will stay on for approximately 10 to 30 seconds. You're going to isolate the tooth with cotton rolls. You're going to dry the tooth. That way you don't have any problems seeing. You're going to try to teach your assistant to keep the mirror dry. And what you're going to do is take that light source, point it away from the patient so you don't squirt air or water at them, have the water off, hit the foot pedal, the light's going to come on, and all you're going to do is you're going to come in on that tooth and you're going to look for that right there, mesial and distal. Actually mesial distal. What I want you to remember is when we see a case like this, and we remove the restoration, and you see it going all the way through, that's going to be a complete split. So what we want to do is understand that there's nothing wrong with removing that restoration for a definitive diagnosis, but we need to make sure the patient's aware before we do any treatment of what could be the result here, which could be an extraction. Not always, but could be. The other thing is we sometimes, I don't know why, but sometimes we're afraid to make a simple incision. If you have tight tissue up, why wouldn't you take a scalpel blade and make a simple incision there, cut the papilla, and reflect the tissue down to see that fracture? It always makes me laugh. People on the clinic floor, they'll go, seriously, you're going to take a scalpel and you're going to cut the papilla? You're going to extract the tooth if I say it's fractured. Really? We're going to talk about traumatic? So why wouldn't you try to confirm it by cutting the papilla and reflecting the tissue down? And sometimes we can send an image like this back to the referrer. That way we see that it's complete split. Now, unfortunately, I don't think we're going to be doing cuspidization here anymore, so that's probably not an option, so chances are it's going to get cold steel and sunshine. Next, sometimes we don't have the norm where when you probe you have that 10 or 12 millimeter. Here I go in for surgery, I have no dehiscence at all. I have only a fenestration when I open it up and I dye it. There it is. That's a fracture in the apical segment. And many of you ask, well, how does that happen? Active post. Please, I'm an endodontist, please stop using screw retained post. I don't know why they're even sold anymore. Active posts don't add anything. All they do is remove. They're removing unnecessary amounts of dentin, and they're flexing dentin more than it should be. Active posts should be banned. We need to make sure we recognize why these things are occurring. Staining. Well, you know, we can stain things. We have to go to this study here. This is Cambrosi and Marshall. This is after Marshall left Ohio State and went to Portland, Oregon. Cambrosi and Marshall showed all the benefits of staining. And many of us use it for surgery when we're trying to find MB2, etc. This here. On behalf of all endodontists, I'm sorry to make concrete rules, but if you think you really need a post and a mesial root of a lower molar, on behalf of all endodontists, please extract the tooth before you actually destroy our outcomes. Because if you're going to put a post in the mesial and distal root, you just start at the clock. My father's an electrical engineer and a civil engineer. My father always says, by the way, not to scare you, your hard drive is going to go on your computer. I just can't tell you when, but when you put a mesial and a distal post, you're going to fracture that tooth. I just can't tell you when. So please, understand what we're forgetting about here. My wife is the best. 2 years ago on Easter, I was sitting with Sergio doing micro CTs and dental cubes. And one of the things we did was we wanted to make sure people understood what they were forgetting in dental school, why we see this right here. It's very simple. If we look at the mesial root of a lower molar and we take a section out of it, we all have to remember that when we look at it mesial distally, that is a beautiful root. That is a big root. But the bottom line is, it's still two-dimensional. And you know, I know it's been a long time, but we can't forget dental anatomy. I know it was the first year of dental school, but we need to remember that when you look at that mesial root, every one of us are forgetting the distal concavity of the mesial root. And after instrumentation, think about how much dentin and cementum you really have left. Why would you ever open that up more and decrease the amount of tooth structure, making it more vulnerable to fracture? We need to maintain and retain tooth structure. That's the real thing. Microendodontics and conservative endodontics is the future. I hope before I retire, somebody comes up with a way that I can access the tooth, take a suction out the pulp, go down with a light, photodynamics, whether it's a Neil Keshen or somebody, and with nanoparticles, forget disinfect, sterilize the tooth, and then seal it off. That would be my dream, okay? If we can do that, we'll be saving teeth a lot longer than we save something else that suffers from periodontitis. I'm not quite sure what that is, but you know what I mean, okay? We have to have better radiographs. Remember, we always get fooled. I just showed you a case where we had the mesial root and we all forgot about the distal concavity. We have to get better radiographs, but what I want to do is I want to share some information with you. People are always worried about taking radiographs. Well, you know what? I did something a long time ago, and so did Brinoff. The first thing I need to mention is Brinoff in 1970, she showed that your diagnostic ability gets close to 90% when you have 3 films. Nobody should ever do endodontic therapy without at least 2 radiographs. When taking radiographs for endodontics, for posterior teeth, you should take one straight shot and one from the distal shooting mesial. Why are we doing that? I want to throw the mesial root of the lower and the mesial buccal root of the upper away from the furcation. Never take a mesial shooting distal, because you're just going to throw everything on top of the tooth. I'm trying to separate the tooth. So I want a straight shot and one shot from the distal shooting mesial for posterior teeth. And for anterior teeth, I want a straight shot and I want to go away from anatomy, so from the mesial shooting distal. Easy trick. Posterior, straight, and distal shooting mesial. Anterior, straight, and mesial shooting distal. The next thing I want to do is I want to make sure everyone realizes that digital radiography does not overexpose your patients. So did an article that, yes, many digital radiography companies quote, but it's not really true. Digital radiography companies try to tell you that digital radiography is 90% less radiation. That's not true. Back in the 90s, I did research, and I actually did step wedges, histograms, and evaluated all digital systems. My results showed that digital radiography is 55% less radiation than D speed and 45% less radiation than E speed, for an average of 50% less radiation. Guess what? 2 for 1. So there's no reason why we shouldn't be taking at least 2 radiographs when we do endodontic therapy as a pre-op. There are a lot of advantages to digital radiography, and the first thing I want to do is, whether or not you're interpreting a result, an outcome, or you're just trying to get working length, remember that nothing's better than digital, because when you take those initial shots, whether it's for diagnosis, whether it's for outcome review, I want you to remember the great advantage of direct sensors is that you can place the sensor, have the patient bite down on that rin, tell the patient not to move or open, and after you expose it, come in without them moving, move your x-ray head. Why is that important? If you go back to all the old studies of Mel, Tensa, and White, Darzenta, guess what? They all showed that no one could put a film in the same place twice, even with a stent. The great news is with digital radiography, you can. You can place it, take a straight shot, come in, and shoot one distal and mesial. You gain that much more information when you do that, because now you have a plate, a sensor in the same spot. But that's the problem. I cannot recommend at this time any of the phosphate plates or anything like that. And the reason is I want a sensor that can stay in there. Okay? Phosphate plates you have to take out and throw into a processor. You're not gaining that benefit. Okay? Next, we have to talk about the way we take radiographs. So let's take a look at this. Why is this tooth failing? Is it really failing? This is not a failure. This is post-treatment disease. Why? If we look at this root, everyone sees the lesion. But why do we see the lesion? We talked about apical periodontitis earlier today. Well, if I come in and I take a shot from the distal in a mesial direction, what do I see? There's a complete system that was never addressed. That's not an endodontic failure. That's post-treatment disease when you miss half of the mesial root. I can't allow anyone to call that an endodontic failure. And if anyone tells me that, well, if you have to retreat an endodontically treated tooth, take it out and put an implant in, why would you ever do that? Why would you do that if you take another radiograph and you see that there's a canal that was never treated? When you know it's all about bugs. I guarantee it's filled with bugs. It makes perfect sense that you have this lesion. We need to get better at understanding morphology, anatomy, and better at diagnosis. So when we take the angled shot, what are we looking for? When Sergio and I did our scans, and Sergio was fantastic, and what he did was he actually took the scan, he took lower molars, cut off the distal root, here's the mesial root. Now, it looks like a great root, but let's really review it. If we come in with that PID, the position indicating device, and we shoot from the distal in a mesial direction, how much information do we really get? This is really the information we're getting. It shows us the extent of the distal concavity. It shows us that this is offset, which is why everyone on the last radiograph, you should have realized that this canal, the reason you know there's a missed canal is this was not in the center. We know that canals are symmetrical. We know they're in the center of the root. We know the pulp chamber is in the middle of the tooth. It was done right here. It was Rankow. So every one of us know the rules. So if we look at these things, we have to remember what we're doing. What about this? Here's a two-dimensional radiograph. It doesn't matter if it's film or digital, but look at this. Why would anyone ever do their diagnosis and endodontic therapy from a radiograph like that? What's really going on here? You have a foreshortened radiograph. If you're not sure if the radiograph is foreshortened, here's the easiest trick I'll ever teach you. I teach my residents every year. Take a Perio probe. Measure from the CEJ to a reproducible reference point like a cusp tip. Go on your digital radiography and measure the same area. If your tooth measures in the mouth as 9 millimeters and your radiograph is 6, obviously that's not normal. And I know some people are going to say, well, didn't someone say that it's not accurate, that it's off by about 1 millimeter? Listen, if something's 9 and something's 6, I don't care about 1 millimeter difference. And you can calibrate that too. But look at this. If you use this one radiograph to do non-surgical endodontic therapy, you're going to have the major problem that most people have, and that is you're going to ledge the case. Because the first thing you need to do before proceeding, if you believe this tooth needs endo, if you completed your diagnosis and you say, this needs endodontic therapy and I'm going to do it, the first thing you need to do is get your estimated working length. And when you do your estimated working length, what are you going to do? You're going to measure from a reference point to here, to here. there's one problem. Because of that radiograph, you're going to have the wrong estimated working length. It's going to be short. Remember that most teeth begin their major curve in the junction between the middle and apical third. This tooth here, if you bring a file to this estimated working length, you're going to legend exactly where it's curving. Not to mention, you missed everything about its perio. Two-dimensional radiograph, three-dimensional world. If you don't have good radiographs, you're preparing for failure and aggravation. We need to take better radiographs when we do treatment and diagnosis. Every one of us know it. And what we need to do is sit down with our assistants. You have to remember, if your assistant is giving you this every time, you can continue doing what you're doing. But the definition of insanity is having the same thing done over and over, thinking there's going to be a different result. If you don't sit with that assistant and train them and teach them what the zygomatic process is and how they place a sensor, you're going to actually go insane. Insanity truly is repeating the same thing over and over and over, expecting a different result. Positioning is everything, everyone. It really is. Positioning is everything. And we even have positioning indicating devices. We have RINs, but people don't want to use them. I don't know why. When you're taking your pre-op radiographs, every one of you should train your assistants, or you should be using a RIN. No one's above it. Whether you're using film or digital radiography, please start using RINs. That's how you minimize the amount of radiation your patients are getting. So you don't have a cone cut, a foreshortened or elongated radiographs. This will help all of us. We need to capture as much information as we can without overexposing our patients. I always want to include the apex and the adjacent teeth when I'm reviewing a case. An example, Friday morning, Donna comes back to me and Donna says, she goes, "Doc, what do you think? Send it to oral surgery?" I'm like, "Donna, if it came to me, I need to evaluate it. I don't see the apex. I don't even know what's going on with the adjacent teeth." I continue doing what I'm doing. Donna comes back in the office and she goes, "How did you know?" I'm like, "Donna, what are you talking about?" She goes, "No, seriously, how did you know?" I'm like, "Donna, I still have no clue." She shows me the radiograph on the screen. It might have been the first implant. Okay? What was the patient's chief complaint? They couldn't eat anything salty or spicy. This tissue looked like hamburger meat back here. That was their chief complaint. Everyone in this room that's been practicing for over 10 years, you know you've had this tooth where the patient's asymptomatic because it's draining around it. There's nothing wrong. There's something else that's bothering them. It's like a little class 2 restoration over here is bothering, but meanwhile you see that still in their mouth. We have to remember that when we take radiographs, we're responsible for everything. We have to take better radiographs. And what does it result in? Rather than my assistant wanting me to extract it, this tooth got retreated and so did this one. A little bit different result. Everyone in this room can have digital radiography come Monday morning. Show of hands, how many people have digital radiography? Okay? We're moving towards digital. The government's moving us towards digital. I'm sure it's all for our own good, but the country is definitely moving towards digitization. Why? Well, some say it's so we can keep cleaner records, but there might be other reasons. How are they going to do it? You'll see it. Within the next 3 to 5 years, all film, all chemicals will be taxed so much that you won't be able to have it. They'll do one break on taxes for basically people buying digital radiography, and that's why you'll buy it. Okay, it'll be a credit. I know exactly how it's going to play out, and it'll probably be within the next 3 to 5 years. But for every one of you, understand that you see the trend because what do insurance companies always ask for? Radiographs. Okay? And what I want you to do is understand that even if you don't have digital radiography today, you can send a radiograph digitally. If you're lecturing to a local study club and you have an old film but you want to show it with your digital today, you can make a digital radiograph. I just want everyone to remember something. Digital radiography is nothing more than binary numbers. Digital radiography is zeros and ones, just like everything else on your computer. All you need to do is make it digital. How do you do it? Real simple. This is a flatbed scanner. When you're driving home this weekend, if you don't have digital radiography in your office, or if you don't have a digital pan in your office, you can have digital pans in your office. Take a pan, buy a flatbed scanner for about $100, but just make sure that you don't buy a flatbed scanner with a small transparency adapter. You want to buy it with a transparency adapter in the entire lid. That will scan the entire pan, the entire occlusal, whatever radiographs, and more importantly, even an old full mouth survey. So you want to buy a flatbed scanner with a transparency adapter in the lid. It goes for about $100. Next, This is a Coolpix camera. Remember those? You can go on eBay and for about $50 buy what's called a Coolpix slide copier adapter. If you have one of these little cameras at home, don't throw it out. Go on eBay, buy a slide copier adapter, put your radiograph in a 35mm slide holder, you put it right here, slide it in front, click a picture, boom, now it's on the card. You can put it in any computer you want. If you want really good images, you want to buy this. Unfortunately, I've been lecturing about this thing here for about the last 2 or 3 years, so they're pretty much gone. But you could go on eBay and buy this. It originally sold for about $2,000 to $3,000. If they show up on eBay, you can grab it for around $300. The reason this is so good, this is what all the photo labs were using to scan film. But now they have automated units that actually change them. That's why they're all selling them. If I cropped these radiographs, you would have never known that this was scanned. That's how good the scans are from this unit. That's digital radiography. It's zeros and ones. It's on the screen. We all have to remember that. No one can define digital radiography for us. And for anyone here who lectures, please, if you have old films and you have a case and you want to put it up, don't forget you can still scan those images in. And you can get good quality. Remember what Guttman told us. In 1992, Guttman described something, and I want everyone to remember the importance of the sequence. We have to remember, diagnosis should indicate the pulpal and periradicular status and the kind of treatment needed to rectify the problem. I want to take it a step further. Please do me a big favor. Whenever you're doing diagnosis, remember the most important thing is come up with your pulpal diagnosis first, then your periradicular diagnosis. Never jump in and come up with your periradicular diagnosis before pulpal. If you do, you're going to miss perioendo lesions. Remember, if you have a perio abscess, that tooth most likely is going to respond normal. If you don't get a pulpal diagnosis, you're just going to think it's an endodontic problem, and it's never going to go away. We have to make sure we carry out these things in the right order. Pulpal diagnosis first, periradicular diagnosis second. The big problem is when we all went to school, we were brainwashed into believing that the only thing we had to do was determine odontogenic from non-odontogenic. The big problem? We have to change the way we do diagnosis. We need, every one of us in this room need to realize that there's odontogenic, non-odontogenic, but under odontogenic, I need to know, is it endodontic or non-endodontic pathology? This is how you get better at diagnosis. I also want you to know that my mentor always told us, never refer to a tooth as vital. You do vitality testing, but you're really trying to determine whether or not the tooth is responsive. And what you're going to do then is ask yourself the next question. If it's responsive, is it responding normally? Because if you just say it's vital, you haven't told yourself anything. We know that from studies from Abbott and everyone, because Abbott has shown numerous times that you can have liquefaction necrosis going on in the distal root and have vital tissue in the mesials. Just because it responded and they delta fiber responded, did that mean that that tooth was healthy? Vital implies healthy. You can't say a tooth is vital and know the diagnosis. That's the worst thing you can do. You're really doing vitality testing. You're not determining if the tooth is vital. We have to realize all the things that we're testing for as dentists. We're doctors first. If we don't take this serious and understand that a typical patient in our office could have vascular pain, atypical facial pain, you can get burned. Remember, it's really sad. Things really do happen and go wrong. We have to remember the importance of diagnosis. Many of you came to this course and you have a 2-day course, and I know some of you right now are saying, I can't believe how long we're spending on diagnosis. I'm going to tell you right now, the hardest thing for me to teach my residents is the future diagnosis they're going to see throughout their years of practice. Diagnosis is everything. Diagnosis is the hardest thing we do. We cannot skimp when it comes to diagnosis. We cannot honestly afford to fall behind. We have to get better at the way we do diagnosis. I think right now we need to improve the way we do it. We have to get better ways of doing it, whether it's Doppler or others. That's got to sound great in your ear. So please remember what we're really looking at here. Before we take a break, I want to make sure every one of us realize the importance of the diagnostic terms that came about in 2009. The American Board of Endodontics has implemented these, so when you do your case portfolio, you have to use these terms. The reason I think they're great, for the first time, we have a normal set of terms, and the reason why I'm telling you about them, as of this year, they're the only terms that will be used on Part 2 of the national boards. These are the terms that we will hear young practitioners use for years to come. Here they are. 1, reversible pulpitis. What are we looking for here? As a general rule, many of us will say there's a non-lingering pain to cold testing or thermal testing. The patient will feel something, they lift their hand, we remove the irritant, it goes down. What's the key number? If we look at everything Cohen and Berman has done and reviewed, the key number for you all is 30 seconds. If it's greater than 30 seconds, you're leaning towards an irreversible pulpitis. So under 30 seconds is your magic number for a reversible pulpitis. The two terms that many of you are probably scratching your head over are symptomatic and asymptomatic irreversible pulpitis. Because when I was in my residency, and many of you were in your school, many of you probably are like, this is all I know. Symptomatic irreversible pulpitis. I put cold on the tooth. They raise their hand. It's lingering. I could see it in their eyes. That's an irreversible pulpitis. But they had to cover a whole nother area, and that's this one, asymptomatic irreversible pulpitis. That's the case that the patient presents to your office with no pain, no lingering. But you see Junior in your chair, and you're like, if I show that tooth a spoon excavator, I'm going to be all the way to the pulpal floor. Meanwhile, Junior has no pain at all. We have to remember that sometimes caries can act as an insulator. We can have a traumatic case that we just don't know the status of the pulp today. That could be an asymptomatic, irreversible pulpitis. So understand that you do a crown prep, that may end up being an asymptomatic, irreversible pulpitis. These are all things that can happen and occur in our office, but this is the most common one for you. This is a symptomatic, irreversible pulpitis, the lingering. When we look at two-dimensional radiographs, we have to be afraid. We have to realize that, yes, there's caries here, but what's the pulp doing? Do we have a calcific metamorphosis going on? Is the pulp horn receding? Why would it recede? Is it responding to an irritant? We have to remember that when we look at an asymptomatic irreversible pulpitis, we may or may not really know what's going on in that pulp histologically. We know that from Seltzer and Bender. The next thing I want to do is I want to show you that even though there's an overlap, look at that bite wing. What is our average treatment plan for tooth number 2? What's the most common treatment plan for tooth number 2? DO, tooth number 2, absolutely. This patient, for a different reason, needed a narrow field cone beam. Remember what I told you earlier, dynamic diagnosis. We do our diagnosis, we come up, we assess, and we come up with a treatment plan for mom and dad. That's something right there, isn't it? I don't think anyone here is saying a DO anymore. See, we're looking at two-dimensional images every single day, but we're working in a three-dimensional world. I just want to make sure everyone here understands the importance of imaging and why we need to take more angles and why no one in this room should ever tell a patient that all they need is an MO or a DO or an MOD. We need to make sure they understand that we will be evaluating that tooth after we remove the caries. It's a continuous process diagnosis. It's not just because a tooth responded or how it responded to a thermal test. Pulpal diagnosis, pulp necrosis, of course there's no response to thermal or electrical stimuli. Previous root canal versus previously initiated. Understand the difference. These are pulpal terms. That's a new shift. Understand that if you have a case that's being retreated or the option is retreatment, it wouldn't even be the same code. Remember, a molar endo is a 3330, a molar retreat's a 3348. A premolar is a 3320, a retreat's 3347. Anterior is 3310, a retreatment of that same anterior is a 3346. Why do I tell you that? How many endodontists I've met over the years don't even know that the two codes pay different amounts of money. We have to utilize the codes properly. Previously initiated therapy, we all need to use as a pulpal term. If any of us get a tooth that's been opened up by someone else, a pulpotomy, a pulpectomy, You need to let the mother or father know of that child that someone else has been in this tooth, and you'll let them know. We don't know by a radiograph whether or not the case is ledged. You need to let the patient know and the parent know that this has been previously initiated. This is not a normal virgin case. You don't know what you're going to find. There could be a strip perf, there could be a regular perforation in the furcal floor, there could be a ledge of the canals, they could be blocked out. We need to make sure we do proper diagnosis and use the terms properly. Pulpal diagnosis has to be done first. When we look at this here, it opens up a whole new storm. After we complete our pulpal, we then look at our periridicular. And we have to remember what happened here in Philadelphia. I was really lucky. When I was up at Harvard, my faculty practice was over at Brigham and Women's Hospital. Well, just by luck, who's head of radiology at Brigham and Women's Hospital? What are the odds? Sam Seltzer's son, Steve Seltzer. So I still got to see some of his dad's old stuff because Steve had everything. And he showed me all the cadaver slides and everything that his father and Bender did. I got to see a lot of stuff. And I want you to remember that you don't see any change until you have a break of that cortical plate, until you have at least 50%. And when we talk about mineralized bone loss, we have to remember that it takes a lot more than you think. So when you look at a radiograph, don't say, oh, there's no lesion, it doesn't need endo. We have to remember that we're looking at the lamina dura. The lamina dura is key. Our periapical diagnosis, the terms have changed a lot. What I want to do is I want to remind everybody that when we look at normal apical tissues, the best person to remember is CAFE. We're looking for that continuous lamina dura. But let me work things in reverse. There's symptomatic and asymptomatic apical periodontitis. An asymptomatic apical periodontitis is that patient you have in the chair, you take a radiograph, you see a lesion, you now percuss the tooth, no pain. You palpate the tooth, no pain. Well, because of that, you go back to percussion, you bang on the tooth some more, still no pain. You now look at the patient and you go, you need a root canal. The patient looks at you, why? I'm not in any pain. You just banged on my tooth, you just palpated my tissue, and I'm not in any pain. Why do I need a root canal? Well, the truth is, they obviously have something going on. We need to determine whether or not it's endodontic in origin. But in that case where you have an asymptomatic apical periodontitis, you sometimes need to remind the patient that eventually you're probably going to need a root canal. The problem is it's going to happen on a weekend or a holiday and I won't be available. So we need to educate the patient and let them know what's going on. They have a lesion with no pain. That same patient comes back to your office 6 months later. Now they're in pain. The old days, we would call that a phoenix abscess. But today, that is now an asymptomatic apical periodontitis 6 months ago, but our dynamic diagnosis has changed. Today, they show up symptomatic. That diagnosis changed to a symptomatic apical periodontitis. Guess what? This patient's normally ready for the root canal. So in the old days, we called this a phoenix abscess. Today, we call it a symptomatic apical periodontitis that is a result of an apical periodontitis previously. The only thing I want to remind everyone is you can have a symptomatic apical periodontitis with or without a radiolucency. See, not all symptomatic apical periodontitis were asymptomatic apical periodontitis. That's just a fact. We have to remember that sometimes you can have pain on biting just because of inflammation, a patient biting on a high restoration. We have to remember the importance of testing our occlusion and seeing what's going on. The best tip I can give you, and we're going to go over a lot of things over the next 2 days, one of the best tips I can ever give you, I don't care if it's an anterior or a premolar, I don't care if it's a molar, remember what Rosenberg said. If you reduce the occlusion following or during endodontic therapy, the patient is less likely to have postoperative pain. If you remove a splinter from someone's finger, even though you remove the irritant, remember you have inflammation. It's going to bother them every time they open a drawer. So we know that they're going to be biting down on this tooth that has inflammation. Why would you have them bite and keep hitting it? It's going to be an irritant. So if you take it out of occlusion, they're less likely to have postoperative pain. A key thing that people just don't do. But if you have an emergency following endo, what's the first thing you do then? Let me check the occlusion. Be proactive. Don't be reactive. Next, acute apical abscess. Key thing here. I want everyone to understand that when you have an acute apical abscess, you have to have swelling. I want to remind everyone the importance of establishing drainage. It was Baumgartner that really summed it up best. We have to remember that when we have swelling, we need to establish drainage. And we need to do it through opening the tooth, and or an IND. But I just want to review some things. Even though we've all been practicing for a while, I want to review the importance of understanding anesthesia. Never, ever, ever give your anesthesia into this lesion. Understand the importance of knowing how to give blocks, even if it's infraorbital, when you're trying to do an IND. The next thing is, even though we know we need to establish drainage, I need everyone in this room to promise me if you're doing an IND, you know how to do an IND. I've trained a lot of residents, and the first thing I have to train them is, even though they learned it in oral surgery, you can't be afraid of a scalpel. You have to go and make sure you go where? Through the periosteum. If you don't feel bone, you're not doing that patient any favors. Once you get through that periosteum, what is the goal? By me going through that and getting drainage, my goal is to decrease the bacterial load, the bacterial byproducts, and even more importantly, the inflammatory mediators. I want to decrease all of that. Now, why were we told when we were in oral surgery rotation to go in there with a hemostat and open it up? Because what do we have? We have little capsules of what? Inflammation. We have what? Edematous tissue. We have to get rid of it. Why? Because you have to go in there and open up and break up these capsules to increase your amount of vasculature. If you don't do that, your IND never works, because if you don't break them up and increase vasculature, your antibiotic can't work. That's why you have to know how to do an IND properly. So establish drainage, IND to the bone. Keep in mind all of your anatomy before you do that. Make sure you give good anesthesia. Chances are you're not going to be able to get profound anesthesia. Get good anesthesia. When you're doing it, you have to break up these capsules. In order to make something heal, it has to be harmed. You need to open it up, increase vasculature, and that way if you give an antibiotic, which you should at that point, then obviously that antibiotic can penetrate. Key points. Chronic apical abscess. I'm sorry, I'm a purist as an endodontist. There's no such thing as a fistula, okay? It's a sinus tract. We know that from Baumgartner. It may or may not be epithelial line. Please use the right terms. And when you talk to young dentists, you're going to hear them say sinus tract. Why? Because we finally corrected it on national boards. It's a sinus tract, not a fistula. Even though you can pick up an insurance book and there it is, fistula. Well, you know what? I'm in Philadelphia. I feel very proud saying this. You're right, there is a fistula. What did Selden tell us? Oral antral fistula. But that's not the sinus tract. An oral antral fistula was described by Selden when he was here in Pennsylvania. When we have a sinus tract, we have to recognize the importance of tracing it, because that's a gift. If you have a sinus tract, please trace that with gutta percha. Now, people always ask me, they're like, you know, when you get these crazy cases with multiple things going on, how does a patient tolerate you doing that? Well, you can't see it, but I do a trick, and I'll share it with anybody that wants to hear it. When you have a sinus tract, yes, you're taking a piston and putting it in a cylinder, and you're backing up pressure. Patients feel that. I don't know why a company hasn't come out with this, but I have a real easy trick. I take a scalpel blade with a 2506 cone, and I cut a groove down it. Why? Because now I have a vent. Even though I'm putting the cone down, I have a vent for pressure. And my patients traditionally have less pain when I try to trace a sinus tract than others. So that's just an easy trick. You take a scalpel blade on a 2506 cone and you just scrape a line right down the center and you try to make it a little bigger. That way there's a vent for that pressure to come out. It's an easy trick. Remember, pulpal diagnosis is key, and that's what I really want to share with everybody here today. So before we take the break, please do me a favor. Let's review this together. Case number 1. What's our pulpal diagnosis for this patient? It's the case I've been showing you all along. Spontaneous pain, it's severe. Their spontaneous pain is severe. It's lingering pain after heat. Guess what? It's relieved by cold. Remember what I told you. Heat sensitivity is reproduced with test. What's their pulpal diagnosis?
Symptomatic irreversible pulpitis.
Symptomatic irreversible pulpitis. Perfect. That's exactly what it is. That's the true definition. That's it. It's symptomatic, okay? And it's irreversible. Next. That patient has mild bite sensitivity and mild percussion sensitivity. These were reproduced in the office. What's the periradicular diagnosis for this patient? Remember, they're sensitive. Symptomatic apical periodontitis. Exactly. That's what I need everyone to understand, that this patient's symptomatic. So even though this isn't a pulpal diagnosis, this is a symptomatic apical periodontitis. They have a symptomatic irreversible pulpitis, and they have a symptomatic apical periodontitis. It's the combination of the two. Next, case number 2, 64-year-old male, asymptomatic bump on the gums. Perio probing, 10 plus millimeters. Percussion positive, palpation positive, bite was negative, and ice, positive response, non-lingering. What's the pulpal diagnosis? Look at you. Normal pulp. Remember, she just did something automatically. When I said earlier, always do your pulpal before your periodicular, she did not look at everything else that was going on. She didn't try to read into that sinus tract right there, being traced with gutta percha. Pulpal diagnosis first. Now the key is, if we have all that right there, let me ask a simple question. If I tell you we have a sinus tract that we can trace and we have a 10 millimeter probing, what's your periodicular diagnosis, or overall, what's your diagnosis? Chronic periodontal abscess. We have to stage our diagnosis just like treatment. That's how we better serve our patients. And unfortunately, there was only one way this thing was going to go, and it was extraction. This is the greatest sheet ever made, and this, I really want to thank Scott McClanahan. It's the same sheet I used when I was at Harvard, and then when the new terms came out, it's what my residents and students have laminated in all their bays. And it helps them determine really what's going on. Chief complaint, history, radiographic findings they should expect, EPT, thermal testing, percussion, etc. I just don't have permission from Scott to give this to the entire world, but I'm working on it. I tried to talk to him in Hawaii about it, but it's something I would love to share with everyone, because this, honestly, he spent a lot of time. He made his first one with Johnson when they were at Bethesda before he went to Minnesota, and this is with the new terms. And I'll try to get this to everybody, and if I do get approval within the next 2 weeks, I'll try to get everyone's email address, and I'll shoot it off as a PDF, okay? Remember, first, do no harm. Diagnosis is the most important thing we do. And what I want to do right now is I just want to remind everybody that it's 25 to 12 and you actually did work through your break. And I want to thank you for it, okay? Before we take lunch break, I want to remind everybody, it really is all about development. Development changes our access and everything. We have to remember that normal development is defined differently for everyone, including children. We have to remember that that pulp is constantly changing. We have to remember that when it comes in, it might have mamelons. But we have to remember, as we age, that tooth is under trauma, whether it's because of caries or occlusion. And you may have a calcific metamorphosis going on. The key point I want you to remember is canals calcify from the top to the bottom. I love when one of my residents comes to me and goes, "Doc, I'm 18 millimeters down, but it's really calcified." I'm like, "What? What are you talking about? Did you forget everything we taught you?" Okay? You probably blocked yourself out. You've probably now ledged it. Congratulations, you're probably on the way to a transportation. And if I didn't get here quick enough, you're about to perforate. Okay? And we have to remember that it really is what is happening to the tooth. So teeth calcify from the top to the bottom. Excess cavity. We have to remember the importance of morphology. Some of my favorite teeth. Maxillary first premolar, please remember from this day forward, that maxillary first premolars, you should always say to yourself, always have 2 canals. If you think of it as always having 2 canals, you'll be on the safe side. What you're really trying to determine is whether or not it has 2 roots or if it's bifurcating in the apical segment. The next tooth is my favorite tooth. Whether I'm doing a live surgery or a live demo, my favorite tooth is maxillary first molar. My favorite, because I'm a righty, when I'm doing stuff live, even if it's a surgery, I love tooth number 14. Number 14 for me is in a perfect spot, especially mesial buccal on a live surgery. This tooth here, it is not an extra canal, everybody, and we're going to discuss that today. MB2 is not extra, okay? Just because you fail to find something doesn't mean it's an extra canal. We need to realize that Stropko showed us a long time ago that 90 to 95% of all mesial buccal roots have a second canal. We just have to get better at locating it. Next, mandibular teeth. We know from Benjamin and Dowson that mandibular incisors, 41.4% of the time, have a second canal. When you have a lower anterior and it's failing, don't think that you have to extract it because it's obviously fractured. It may be that there's another canal that's missed. When it is missed, it's normally towards the lingual. The primary canal is normally centered. That's what throws people off. So what you want to do is you want to get an endo explorer and come from the incisal ledge and on a 45-degree angle go towards the cingulum and see if you get a stick. That's where people miss it. It's underneath the shelf. Next, and one of my personal favorites, lower molars are very prone to ethnic variations, especially Native American Indians, Eskimos, and Asians. And one of the common things you see is the number 4 dice. The thing you have to look out for is whether or not you have 2 roots, and the other thing you have to watch out for is whether or not you have a middle mesial in between the 2 mesials. The other ethnic variation is premolars. Native American Indians are known for having 3 roots. Okay, and I've got the Shinnecock Indians, and I'm telling you 100% of all Shinnecock Indians have 3 roots. I can tell you if they're really Shinnecock Indian by whether or not they have 3 rooted premolars. Okay?